everyone for attending this event tonight with us. For those of you who don't know us already, we are ASA, the African Student Association. We aim to create a space for people of African descent here in this institute, but also for people who are interested and want to take part in African-related topics and activities. This academic year marks our 10th anniversary. And this event illustrates our trajectory for this year, which is amplifying African voices. We are honored to not only be able to shed light on, but also learn from pioneering African minds. And in this trend, and as some of you already know, we've launched our mentorship program last week when admissions opened. This program is designed for students in this institute who wish to mentor and assist prospective students of African descent with their applications to master's and PhD programs. So applications are open until November 15. And for those of you who would like to mentor, please send us an email with your CV and your area of expertise. We will greatly appreciate it. And so I would like to warmly thank our partners and collaborators for your support and your endorsement. Thank you so much to Dr. Kelly Chibale and Professor Angèle Mendy for being with us and sharing your expertise and experience. Thank you so much. Thank you to Professor Dejila. We are very grateful for your support. Thank you so much. He's not here, but he's with us in spirit, you know. So yeah. And finally, thank you so much to ASA and our wonderful team. You put in so much work and it truly shows. So without further ado, I will give the floor to our amazing moderators, Haddy and Kenny.
Before we introduce the event, we thought it would be nice also to present a bit ourselves so you know who we are and what we do here. So I'm Kenny, nice to meet you. I'm a student at the graduate program in second year. I'm studying international studies and development with a track on migration. And I have a special interest in this topic today, so migration and healthcare in Africa, as I'm also doing an internship on the side with Doctor Without Borders. So that's why I'm also doing this moderation today. And over to Haddy.
Thank you, Kenny. Hello, everybody. My name is Haddy. I'm a first-year International Development Studies student in the Global Health track. So this is my bread and butter, and I'm excited to moderate this conversation and get your insights and also your insights coming in. So thank you for coming. All right, so without further ado, we can get started. Good evening, everybody, and thank you for joining us for this important discussion on bridging healthcare inequalities, African agency and innovation and access to medicine. We are honored to welcome you to what promises to be a very interesting conversation on Africa's healthcare landscape and its aspirations for a stronger future. So as you may know, the COVID-19 pandemic clearly exposed the disparities that exist not only between Africa and other countries, but within Africa itself. While many regions around the world were able to mobilize resources swiftly, Africa faced unique challenges. For example, in mid-2021, less than 2% of Africa's population had been fully vaccinated, compared to high-income countries that had about 41% of their population vaccinated, which exposed the continent's reliance on external support and stressed the need for self-reliant healthcare infrastructure.
But the disparities within Africa itself are also very evident. Just to make a general comment, some countries have made significant efforts in building healthcare capacity and training medical personnel, while others continue to struggle with basic healthcare access. For instance, in Niger, we see that there is approximately 0.2 doctors for 10,000 people, whereas in South Africa, this is closer to 9 for 10,000. For reference, in Switzerland or in Europe, we are around 40 doctors for 10,000 people. So the last one we want to point out before we go is that Africa is still struggling with diseases like malaria, tuberculosis, cholera, different outbreaks. And to make a point that all of those, they take a significant toll on African population, but they are almost eradicated or under control in other parts of the world. So our discussion today, we will delve into the challenges of healthcare inequalities in Africa and explore what can be done to build a more resilient healthcare system. That's going from initiative, drug discoveries and their fundings, but also from the symptoms and remedies of brain drain. To help us navigate, we have two distinguished experts, Professor Angèle Mendy and Dr. Kelly Chibale. So just to give you an idea, guys, we will first have around 40 minutes of present discussion and questions for our two people here, and then we will open the floor to all the questions. Please keep it at the end because we'll have a 1 hour discussion and exchange between all of us. I think it's a good way to delve on that topic. We will just start by making a little resume of our two guests. So to start with Professor Angèle Mendy. So she's currently a visiting lecturer at the Graduate Institute, as well as a visiting scientist at the Harvard T.H. Chan School of Public Health, so Harvard School of Public Health. She is currently teaching at the Graduate Institute, so the course of Migration and Health from an international perspective, but also the introduction class of the global track. She's also a faculty lead for the ARP project, and I'm sure that those of you who are in the Institute knows what it is. She holds a Bachelor and a Master of Sociology from the University of Saint Louis in Senegal, and as well a PhD of the University of Lausanne. She was also a senior lecturer in some universities in Switzerland, ranging from Neuchâtel to Lausanne. At the Harvard School of Public Health, she did a postdoc training in global health, and she's currently supporting a Dr. Jesse Bums, whose research focuses on the historical roots on health inequalities, the logic of domination of resources, but as well as the control of medical knowledge in global health in Africa. She has published many articles on the subject and also is an author of the book Être médecin africain en Europe, published in 2016, so to be a medical doctor, African medical doctor in Europe. So you will have understood from her career that she specializes in the study of African health workers inside, but also outside of Africa, and the impact they have on their healthcare systems. Over to you.
Thank you, Kenny. And so over to Dr. Kelly Chibale. So Dr. Kelly Chibale is a Zambian biochemist and professor of organic chemistry at the University of Cape Town, and a leading figure in the fight against infectious diseases in Africa. He holds a Bachelor of Science degree in chemistry from the University of Zambia, and a PhD in synthetic organic chemistry from the University of Cambridge. Following this, Dr. Chibale did a number of postdoctoral stints, fellowships, and research in the United States and the United Kingdom. Additionally, as the founder and director of the Drug Discovery and Development Center, or H3D, at the University of Cape Town, Dr. Chibale spearheads groundbreaking research focused on malaria, antibiotic-resistant microbial diseases, and tuberculosis. His work emphasizes the need for local solutions to health challenges, fostering collaboration between academic institutions, the pharmaceutical industry, and public health organizations. Today, he holds the Neville Isdell Chair in African-centric drug discovery and development at the University of Cape Town, and is a full member of the UCT Institute of Infectious Diseases and Molecular Medicine. His contributions to science and public health have earned him numerous accolades, such as being featured as one of Fortune magazine's top 15 world's greatest leaders, and in 2023, an honorary doctorate of the Faculty of Science at the University of Basel here in Switzerland. He continues to inspire the next generation of scientists through mentorship and education. Give a round of applause for him.
Thank you. Okay, so the first topic will be addressed by Dr. Angèle Mendy over here. So to go back to a bit what we said in the introduction, a recent policy brief published by the African Union in 2020 showed that there is approximately 13 health workers for 10,000 people in Africa across the country. So from doctors to nurses to whoever is working in the healthcare program. To compare it for the worldwide average, this is 43 for 10,000 people, and in the European, it's almost more than 120 people. So my first question is addressing that. It's estimated that by the year 2030, that we will have a shortage of 6.1 million African health workers in Africa. So, in short, how does the migration of African health professionals affect healthcare access on the continent?
Thanks so much, everyone, for inviting us discussing this great topic of migration, but also the situation of our health system in Africa. I think first of all, to answer your question, I would say that, okay, this link between the situation of health system in Africa and the weakness of our system and also the migration of health system, I will add the shortage of health professionals. We can all include all of these in the same topic, the conditions of development in Africa, in our countries, because we can't talk about the shortage of health professionals without just asking what kind of conditions they have. The first thing, what resources they have just to give like health services or provide health services to their populations. I may say that we need to strengthen our health system first. Strengthening the health system in Africa means having a kind of good and efficient policy that fits need to the population. This is one thing. And also, we don't have to refer only on what we call the number of the health professional, putting in link with the population. We have to ask to just see the need, real need of population, the kind of health need they have, the kind of health professional we mostly need inside our countries within the health systems. This is all the prerequisite question I just would like to stress out before just talking about this question of shortage, but also the question of brain training. So what I may say as health professional, if we give to health professional conditions, alternative conditions to work or to stay in the continent, and give them the opportunity to be involved in the need of health need of population, I think that this kind of discussion, or we will arrive to find solution on what our health system and what our population needs. We here sitting discussing about health system inequalities and need of health population. But for me, where we really need to focus is on asking to those who are really involved, what are your needs? What explain or just what justify this inequality, global or international inequalities between European countries or global north and the global south, mostly African countries. This is the kind of question we need to raise before just discussing or focusing on what really explains the health professional, the shortage of health professional. Maybe at this point, as you have the view of medical professional or medical, just say, practitioner, you may just complete this point before I just continue.
Yeah, I think, so first of all, thank you very much for having us. It's a real honor, it's a real privilege to be here. So maybe just to add to this point, I think when the moderator was making the opening remarks, I think you made a very important point about what the COVID-19 pandemic laid bare in terms of Africa. And it's not just a case of bolstering the public health infrastructure, but it's also the skill shortage, which is made worse by the brain drain. So I think it's to understand what are the needs of the people who end up living. It's not easy to leave home. That's what you're used to. So there must be something quite significant that makes one want to leave home. So I think yes, I completely agree. We have to establish what are the needs. But the question is, do the powers that be, then are they in a position to to address those issues?
Okay, I will have like two perspectives, so I prepared two perspectives to discuss this question first. When we're talking about brain drain, so we put it in link with migration. So migration does not necessarily just link to the brain drain. Migration also may be kind of solution just to strengthen our health system. So I'm going to develop on these 2 points. First of all, of course, when we take migration and put it in link with brain drain, it's because those who just left the continent or leave the continent to find better condition in the other countries, left behind maybe difficult condition of exercise, left behind as a lack of opportunity to do their best or to offer their best based on their skill. They also left behind a very weak system. When I joined Harvard in 2020, it was for studying and conceptualizing what I call a weakness system, a weak system, health system. So this weak system, taking the example of the Gambia, means that you are very qualified as health professional. You would like to give your best to just offer your services, put your skills at the disposal of the population. But you're facing challenge like lack of efficient policy, incentive, opportunities that help you just or give you the minimum condition of practice. Also, working condition, I will say living condition, I will say sometimes they want to specialize themselves in one area, they don't have these opportunities. Of course, I will include their salaries. So all of these challenge, we all know how health professionals face in Africa. This is the first thing. So when they are facing these challenges and they decide to move abroad, and then in the public discourse, in public, let's say discussion, we're talking about brain drain. We already know where the problems are. It's the conditions they left behind. So what I think is, if you would like just to solve these kind of problems, maybe let us give the kind of alternative to this health professional. What the nature of this alternative is just strengthen the health system, improve the system, because we can't ask them to stay. We're in a globalizing world. If we just tell them you must stay because you have to strengthen the health system, without giving them the opportunity and the condition to do so, it's just like you're going to try, but you will just face failed policies as we experiment in many countries I just studied. The other thing is, I think we need to stop, as we are in an academic area, we need to stop to put in relation migration, brain drain, and shortage of health professionals. Because we also can put in link migration and improving the health system by diaspora or just by those health professional migrants who are just migrating to other countries, not only Western country, but let us say South migration as well. This is important. We are in a globalizing world. The international law promotes now, or mobility, promotes the mobility of skills professionals. Why not asking Africans professionals to stay in Africa because the continent or the health system face a challenge? Why don't facilitate their mobility between the continent? Give them the opportunity by showing that we implementing incentive policies. We just improve the infrastructure. We're trying to implement the universal health coverage. We're trying just to put a kind of very good policy of drugs to avoid like these counterfeit drugs our population in Africa face. Sometimes these are the cause of mortality, these counterfeit drugs. So for the local perspective, improving the condition of working as an alternative to those who just migrate and gives them the opportunity to choose whether they're going to work part-time here, part-time there, is a way we can improve her situation, health situation. Not just every time make them feel guilty by saying them that, okay, it's because you migrate. This migration causes brain drain. This explains the shortage of health professionals. In my sense, we need to give opportunities, as the other countries just improve their health system, to allow them to go and come, to return, because they can contribute, whether they're in Africa or whether they're in the other continent. But I think that being migrant means also contribute, maybe remotely, but it's all. My last point is alternative. Give alternative to health professionals. We will just solve one of the part of the problem.
Thank you for the questions.
So maybe just to add another perspective to the brain drain. So the brain drain migration is a scenario where the health professional who's already based in Africa moves out of Africa for whatever reason. But there's another aspect to the brain drain where people get sent for training, let's say in the developed world, and then they discover opportunities when they're here, and so they don't go back because there isn't the infrastructure for them to practice what they have learned. So we still lose talent because there isn't the infrastructure back home to provide that environment to allow them to practice what they learned. So even when the diaspora could contribute, some people, I know people who want to come back and give something back.
Yes.
But when they see the infrastructure that is already there, when they see how the people that have remained, how they are treated, then it's very difficult to then convince them to come and contribute. Because the people who are already there are not taken care of. So it doesn't encourage them to want to come back. So sorting out the infrastructure and the systems could also help people who are sent for training abroad might then feel that when they go back, they can contribute to the system.
It's what I just consider as the whole conditions that need to be improved to give them this opportunity. You're right, when I'm doing my PhD, just doing interview with those from Cameroon, they were explaining me this phenomenon of being very motivated to return in Africa. And when you arrive in your country thinking that you came with skills, you're very good, motivated to stay. And they just facing this kind of discouragement because your own country don't just take you, country don't just accept you or your colleague. They don't open the door to leave you just for what you know. And of course the infrastructure limit. But beyond the infrastructure, what about resources? Because it's all about resources. Having the resource to improve the condition, having resource to giving a kind of good condition, good salary to those who are just spending their time, giving their time. Because we're talking about health system. We're not talking about university, but it's the place where you treat people, patients, and facing very difficult condition of treatment.
Thank you. Maybe to work a bit on that. So we know we're talking about Africa. It's a large continent. There are very different, conditions. But the second question we had was to talk a bit on that. What could be done by African countries actually to improve that and to prevent this this brain drain, what strategies, if we could to answer that a bit more? Because we know there are some countries, we have the example of Botswana, which is a country who has free healthcare system more or less for everyone, and you have other countries most countries you have to pay upfront before you can access healthcare. So you have different systems that are on place, but the question we wanted to ask, is, what can they do to leverage the expertise of their diaspora while also improving the local healthcare system? So to follow a bit on this conversation.
What we know during COVID-19, I just remember the first discourse from the United Nations here saying that Africa was a global threat. Africa was in a situation where if we don't just intervene quickly, so we will have death, people will die because. But the conclusion, the finding I just got from my study, studying the Gambia, how they deal with the COVID-19, shows that in Africa, it's just not only a question of challenge, a question of weakness of the health system, but let me tell you that we have experts, a very good expert, health experts, qualified health professionals that face the COVID-19 pandemic better than from the global, let's say, global north. I talked with people who, health professionals, of course, in Senegal, the Gambia, and Cameroon, and Burkina Faso as well. They are there, but they were telling me that they were ready to face COVID-19 because they experienced previous infection disease. This is one thing. So the other thing is, I think if we would like to solve these problems, I may just suggest working the law, the policy, migration policy, to just give the opportunities of those who would like to contribute where they are, facing this kind of difficult integration or return, to just work from there and help to strengthen, share their knowledge. This is the first thing, it's important. We can't just implement some policies while the legislation doesn't follow. So adapting laws in countries, giving opportunity to those who are outside the country and those who are inside the country to have this mobility, because we are in a special system, like academics, health professionals, they need to move from one place to the other to acquire experiences, specialization, etc. This is for me important. The other thing is, those who are leading the health system in Africa, we need to put in place, like, if you have ability and competency to lead a health system, they put you there. So you will see how just to articulate need of population, like resource need to reach these needs, and health services that need. But what's happened in most African countries, you will see like politicians have been just who lead the health system. So sometimes we have this problem of leadership as well. It's simple. Resource, leadership, and adapt the new context to the need of health professionals that are in mobility. Because when you just dealing with them, they tell you that sometimes we need to move to find experiences. Of course, I'm not saying that those who just join one developing country compare the situation and refuse to come back, but it's more complex than what we think. For me, it's just giving them opportunity, alternative, so just leaving them. Because in the other country, if I take the case of France, they are facing shortage of health professionals. Of course, if we take like Switzerland recruit. So it's all about how they consider the problem and just bring solution to the problem. It's going to be all about how we're facing our problems in Africa, health problems. Think about it. and just propose, adapt solutions, not just like discussing theoretically, but we need
public sector, and governments, but the private sector has a role to play in this. And I think that's is a major gap. We don't really get the private sector engaging with the public sector. One of the things that COVID-19 showed us, and that's why you saw the progress that was made in COVID-19. It's almost like a blueprint of how to solve problems. So we saw unprecedented levels of collaboration, but also partnerships between the public sector and the private sector. And that's how we could find a solution very quickly. So I think the over-reliance on the public sector is a major problem. And I think that we should also hold the private sector accountable for that as well.
One interesting finding we just got. I'm working on a project with the World Bank. Is just quick summarizing. Those countries, low and middle income countries, that success just to implement a good human resource policies are those who just have a very strong institutional and administrative structure first. And you're talking about private sector. I think in Africa, some of the countries like West African country, I bet knows, and the others, what I know is that leaving the private sector integrate, of course, they participate in the provision of health services, but I think that we need a strong public sector before opening, because if not, we will have a kind of imbalance between what the public sector should give first, like universal health coverage, and then integrating the private sector. As we have clinics, we have hospitals, but it's look like more you have the development of private sector in our countries, in some African countries, it's just like you have a public sector that just stop giving the quality we just are expecting on health services to the population. It's this kind of imbalance between private sector and public sectors that we need also to consider. Because if you have a very strong public sector, you may also have like a regulation law that just regulate the private sector in this, because they are making profit, and we are in a health system, and we are in Africa with a population without insurance. Sometimes they cannot afford paying for just benefit from this private sector. It's maybe, controversial, but I think it's a good point.
So just to clarify, so I think what she's talking about is more having private healthcare, private insurance. But what I was talking about is partnerships between the private sector and the public sector, for example, to develop infrastructure. So some of these people work for these private companies, but they don't have private medical insurance. They rely on the public sector hospitals, for example. So, because those workers work for those companies, private companies, it is in the interest of the companies to contribute to developing the infrastructure, health systems that those people then can have access to. But it is not having private healthcare, no, that's for people who can afford.
Yes.
It happens everywhere in the world. But I think it's having this infrastructure, public infrastructure that the private sector can contribute to in partnership with government for the benefit of those workers who work for those private companies that don't have private healthcare.
Dr. Kelly, you mentioned partnerships, so would you be able to tell us more about H3D and what strides have been made in Africa in the drug development sector, and how that can be scaled globally, and what impact that African medicine can have on the global scale?
Yeah, so H3D the H stands for holistic. Of course, 3 is a number, and then the 3 Ds. The first D is drug, the second D is discovery, and the third D is development. This is a drug discovery center that's based at the University of Cape Town. So it's not a legal entity, it's part of the University of Cape Town. And it was founded in 2010, towards the end of 2010. And the programs started officially in April of 2011. And before the establishment of H3D, the question that we really had to think about is what is really driving the establishment of this organization. And I think you mentioned very nicely in your introduction, one of the things that COVID-19 laid bare, which we of course knew this before even COVID-19, was the importance of local innovation. Not only to charter homegrown solutions, but also to leapfrog some of the barriers that might come as a consequence of supply chain issues when every country has a right to prioritize their citizens. That's fair. So it's really thinking about, first of all, my continent has a very high disease burden. But these diseases are not African diseases, they are human diseases, they are human problems. So the question is, what can I do as an African to contribute solutions to this? So we have to accept also, for example, we in Africa have also been beneficiaries of discoveries and innovations that have taken place elsewhere. So I think when we talk about partnerships, the question is, what are you bringing to the table? So partnerships can only be equal if you are bringing something to the table that the other person doesn't have. So I think that the first reason was really that we as Africans have to think about contributing solutions, not just be beneficiaries of someone else's solutions. But the second reason for establishing the center is what I like to call scientific entrepreneurship. This is entrepreneurship. Why? We're talking about the brain drain and the skills and so on and so forth. One of the reasons why people leave is that we don't create this absorptive capacity to attract the talent, to develop it, to nurture it, and to retain it. So people, they have to look after themselves and their families. Why not? People are free to move. So in thinking about that, we then set out to establish the infrastructure, because it didn't exist. So I moved to Cape Town from San Diego in 1996. And so we had to build everything from scratch. What I noticed were two extremes. The one extreme was there was a lot of clinical trials being done in South Africa and wonderful clinicians. And then the other extreme was you have a number of good academic institutions doing good basic research. But this chasm, this gap between the lab and the patient, this translation aspect is what we felt. So to answer your question, I took a sabbatical. I went to Pfizer in the UK so I could learn about how to set up a drug discovery organization at the level of infrastructure, technologies, and talent. So when we set it up, we didn't have everything. And this will emphasize the issue of partnerships, as I answer your question. So in April of 2011, I only had 5 chemists, postdoctoral scientists. Today, I have 75 people in this space across chemistry, biology, pharmacology, business development, operations, project management. This is creating jobs. But this is all been done because we had partners. We didn't have everything in 2011. If you compare 2011 to what we have today, we didn't have everything. So it was basically a model of networks of partnerships. Why was those partnerships possible? There was mutual interest. Because there was mutual interest, there was mutual responsibility we had to do. So, the second part of your question is, what are we doing to scale this up across the continent? And that is a program that we started recently called the Grand Challenges Africa Drug Discovery Accelerator Initiative. And the reason is that we cannot do this alone in South Africa. In order for all of us to benefit from economies of scale, for this to make business sense, to solve some of the infrastructure problems like procurement. This is one of the biggest problems, reagents. You cannot do research when it takes you 6 months or 1 year, 6, 8 months to order a chemical and receive it. And we cannot have customs and immigration officials who make it difficult for you to bring these research chemicals into the country or even receive a piece of equipment. So this initiative, we're calling Grand Challenges African Drug Discovery Accelerator, or GCADA, is basically an initiative to expand the ecosystem and community of drug discovery in Africa, focused on the model of saying we don't have everything now, we don't need to have everything now, but we focus on doing what we can do to contribute to a Pan-African project, trying to solve malaria or whatever, but we contribute from our home institution with what we have, and then other partners in other parts of Africa in the network who are able to provide what we don't have, then contribute to that project. So it is a model that we used to grow H3D to what it is today, is working with partners on a globally aligned project and focusing on what we can do and what we couldn't do because we didn't have everything, our partners then would contribute them. So in a nutshell, that's what we've done to create this network. There are about 8 African countries involved. This was just established this year. The press announcement was in April this year. We have 8 African countries and about 21 institutions participating in this initiative. And so it's very exciting. But it's also because of what we have been able to do in H3D. People didn't believe that we could do this in Cape Town, in South Africa. And apart from building this world-class drug discovery infrastructure that has attracted partnership from the pharmaceutical companies and other organizations, we also have made some discoveries of drugs that went into clinical studies from scratch up to the clinic. So we've shown that it's possible to do this. And we've managed to attract talent, including, you talk about migration, we've managed to attract people from California, from Boston, who came to Cape Town because we built the infrastructure first. When we build the infrastructure, we build the systems, people will come. They will come to Africa, not people leaving Africa.
Absolutely. Well, you actually answered my second question within this one, so I'm going to go to one of the bonus questions that we had. So when we were doing some research, we found that as it stands, only 3% of clinical trials for drugs are conducted on the African continent, which is something that you mentioned also. So this poses an issue in the production of drugs that need to be suited to varied genetic profiles as well. And you mentioned the advocacy from health experts like yourself as a solution, but what other avenues can be taken to improve this issue of lack of?
Thank you so much. So I'm sure, I don't know if people really know this statistic. Our continent is arguably the most genetically diverse continent. And people say actually all humans are African. Every human came from Africa. Just some Africans chose to live in some cold, miserable places. And the wise ones stayed behind. So this huge genetic diversity, when I say diversity, it's not homogeneous. You know, Africa is not a country, it's a continent. So you know, the African in West Africa is not the same African in Southern Africa, etc., etc. So historically, exactly to your point that you made, as things stand right now, so we make up about 15% of the global population and account for about 20% of the disease burden, and yet we have such a low volume of clinical trials. And of course, the implication of this is that the African perspective in terms of our intrinsic factors, like the physiology of an African, the genetics of an African, is not considered. Secondly, extrinsic factors like the way we in Africa practice medicine. In other words, at what stage does the typical African patient present themselves to a doctor? Normally it's much later. Then there's of course the issue of concomitant medications. You know, most of our people still resort to the use of traditional medicines, which have not been well scientifically validated or studied in terms of clinical trials to provide safety data to help people be informed about what they're taking. So, one of the reasons, of course, why there is such a huge variability in the way people respond to medicines is because of these genetic differences in the expression and activity of what we call drug metabolizing enzymes. So with the body, whether it's the food we eat or the chemicals we take through medicines, what goes in must get out. But that process is enabled by metabolism or breakdown of substances. So to answer your question, what needs to be done to change this? Just focusing on clinical trials. There are many reasons why we have such a low volume. And maybe I'll just, in the interest of time, maybe just mention three, which is what we need to address. Let me start with the one on policy. In many countries around the world, the regulator of a particular country will not consider a product if it has not been tested on the local population. In African governments, African countries, there is no such requirement. So if there's no requirement, why should anybody bother to do the clinical trial in Africa? So part of it is our own fault. Unless we have the policies that require, demand that you need to show us data from clinical trials tested on our people, because we want to see how they respond. So that will force the issue of then doing more trials and the capacity to do more trials. So that's the first thing, policy. Secondly, harmonization of the regulatory environment. When you go to Brussels, you submit a dossier to ask for a clinical trial or to approve a medicine. You get a yes or no from Brussels. You don't have to do it in every EU country because they have this they have one unified framework for doing that. And in other countries that are even outside the EU, there's mutual recognition. So you don't have to go through the same process, which means it's shorter and it's efficient. In Africa, things are changing for the better, I must say. But historically, every country have their own regulations. A company that wants to do a clinical trial has to go to every country to apply for that and then look at the cost of doing that, which then has to be passed on to the patients. So what is encouraging now, and this is a positive thing, is now this establishment of the African Medicines Agency. However, although that will bring some degree of harmonization in terms of ethics and policies, etc., it's not going to replace the national regulators. But what we need more is this regional harmonization. And there are some very good examples of this already. There's one entity called Zazibona, Zambia, Zimbabwe, Botswana, Namibia. The regulators in these countries mutually recognize the work of the other. So you don't have to repeat that. Okay, so second point is we have had a lack of harmonization to do this. I think a third one is skills, capacity to handle dossiers. I served on the board of a local regulator in South Africa called SAPRA. And it is quite, the first thing we did as board members, we shouldn't have been doing that. We had to deal with a backlog of 5,000, more than 5,000 dossiers, which were waiting to be reviewed because there was no capacity to do that. So instead of focusing on streamlining approvals, we had to focus on clearing the backlog of dossiers. So those are the three things I can share with you that need to be addressed. We need to have the right policies that require you need to do a clinical trial in Africa before we can approve your medicine. Secondly, we need capacity. You know, people have the skills to do this, and we need to harmonize the environment.
Thank you. So should we go to the final question for both of our speakers?
I think we
Would
could
you want
already
to
open the floor now. Thank you for the first round of questions. Thank you so much. Very interesting. And I'm sure there's a lot of questions from the audience, so we'll go there first. Yes, go ahead.
A little bit of a devil's advocate. Thank you for talking about the brain drain. And thank you so much for the H3D Foundation in Cape Town. I actually live 3 minutes from your place. But I have a few pronged questions. First is on the brain drain issue. And I think I agree partly with what you're saying in terms of reducing the inequalities and also optimizing or sort of making Africa attractive for the doctors who go elsewhere to get skills, which I think is essential. Like you also have mentioned here that because of the H3D, it's attracting the doctors to come back home. But seeing like what you have done with the H3D, and also there's, I don't know if you know Potawira. It's an organization in Malawi. It's a woman who saw the same thing. She went to get educated in Oregon. She came back, now it's a whole community, it's a holistic thing. So I understand this thing of incentivizing doctors and letting them stay, having sort of a foot in and a foot out. And I don't really know how. I think it's going to be helpful on the part of them getting skills and then still coming back to work in Africa. But it's not really. I think there's going to be a sense of detachment. Because what is wrong with getting the skills? And yes, there's so many things that could hinder them from coming back and fully giving their whole attention to Africa and the issues that are there, right? But I just don't see how it's going to solve the issue that we have, because we don't have the time and we don't have to always be focusing on fighting the policy and the infrastructure. That's going to be it's going to take a long period of time. Because we can see so many countries in Africa that are much older, for example, than South Africa in terms of democracy, but they're still so many years behind in so many sectors. So should we really focus on the fact that they are not very good infrastructures for them when we can just actually create them ourselves by them having a foot in and a foot out? I don't know if that made sense, but I was just thinking about when you were talking.
Yeah, thank you so much for coming with this question. I would just say that I usually face it kind of reflection, but let me tell you that the development of a country or development of a national sector, we don't have to take it on the shoulder of one category of health professional or professionals. If we take the example saying that, okay, they don't have to look at the infrastructure and they just have to aid. Countries that develop their health system, they take time to do it. We can impose African professionals to return in Africa and work while the others are just moved from one country to the other. The right of mobility is a human right. Considering this in a low perspective, we should just turn the reflection, saying that as everyone has the right to just do mobility or just go from one place to the other, why not in the national level preparing or just strengthening? We're talking about health system and inequalities. Why not strengthening the health system and give them the alternative as the other countries did? Switzerland or France or the European countries or the other countries, Latin, etc., some of the countries strengthen their health system, their infrastructure, improve their policies, national policies, and leave those people, these persons, these health professionals who have the right to move, to make their choice. And I'm teaching as well decolonizing global health. So what we usually discuss as well is, do we have the same discussion when it's came to talking about the brain drain of those coming from developing country to more developing country? I'm giving an example. The concept of brain drain came from the Great Britain, where in 1947, they just nationalizing the system. Those doctors that decide to move from the UK to join Australia, USA, etc. It's journalists who said, okay, shame on you, you leaving your population because now we nationalize the system and you move abroad. So in my perspective, I think that we should not just focus on you should go, you must do because people are dying, because we are in the country of disease. Let us see the things in the other side. Improve the system. Developing national policies is a long-term process, for sure. We don't have to underestimate the effort that you just gave this example. We need to just have this case study to know that, oh, in South Africa, things are going, let's say, are improving. But if we just take the same topic of brain drain in Africa, in South Africa, it's like a very controversial as well topic inside, despite the fact that you show us that you're doing very well inside, you're trying to attract them, but they are all around the world. I did interview in the UK, they are there, Canada, they are there, around the world. So give them this opportunity of doing mobility. And just to decolonizing her mind, I just suggest to do not focus on thinking that Africans, because of the health situation of the continent, health professionals I studied during 10 years must return in Africa. They can contribute wherever they are, but just leave them do so and focus on improving to attract this kind of skills that decide to invest there. I'm sure that you're in need in South Africa because maybe the health policy just gives this opportunity to be there, to just settle and just having this, implement this kind of initiative and maybe recruiting those who have the skills to give you satisfaction. While in the other countries, this is the South African example, let us say the most best case studies we can just talking about here. But let us take the other countries. I'm from Senegal. Maybe in Senegal we're talking about producing this Institut Pasteur, by the way, which is the French private sector as well, part of the institution. Let us take the example of Burkina Faso, Niger, and the other countries. Of course, one example may give us like motivation to return in Africa or consider the case of Africa, but the realities sometimes are very different if we compare them to the successful stories we can share.
If I could just make 3 quick points. So first of all, the focus on this migration is always people leaving Africa to the global north. What we don't talk about is actually migration within Africa. I know many people, for example, going to Rwanda to work. Doctors going to work in Rwanda because the infrastructure there is there. I know people going to Botswana. It happened many years ago. So I think the principle here is that even within Africa, those countries that have taken care of the infrastructure also attract people from other African countries. I think that's an example that countries can learn from each other, that it's not just losing talent to the global north, that we also lose talent to other fellow African countries in the country. So that's the first thing, is that we mustn't forget that this migration is not just outside Africa, it's also within Africa. Secondly, all things being equal, you can sort out the infrastructure, people can come here, but unless there is political stability, a lot of the problems that we have destroy everything. Even if you have infrastructure, then you have this political nonsense that just makes it difficult for anyone to do anything. So I think we have to be very mindful that we also need to stabilize countries politically. Otherwise, when there's turmoil, political turmoil, everything just falls apart. My final point is this: people like to always say, "Oh, but South Africa is better off." No. You only have to come to Cape Town to see the inequality that is in South Africa. It is the most unequal society. I come from Zambia myself originally. I know what poverty means. I know what it means to grow up in a town here. But the inequality that you see in South Africa is enormous. Now, the government can simply say, oh, we're not going to put money into science or whatever because we need to build houses for people. Makes sense. So, it's about priority. Any country, there is a budget, the government decides how much is going to health, how much is going to education, how much is going to the military. It's priorities. So I think what is a priority for each country, they must decide for themselves.
Yeah, thank you. My name is Arin Zay. I'm with the Global Fund. I actually wanted to ask a question in line with your last statement. When we look at countries like mine, Nigeria, where a lot of the decision makers and political leaders are more politicians than technocrats, they're often faced with this dilemma on whether or not to invest in the health system. And the reason for that, and also to touch on the brain drain question, is when health professionals leave the country, they do so because they're seeking greener pastures, and not because the facilities are not there, not because the health infrastructure is not there, not because there is not enough health system strengthening, but because they will most likely get better salary in another country. And so that, in the minds of the politicians, let us invest in economic development. Let's do things that would make people feel like staying at home, like housing or providing better security or even electricity. And so it makes the case for them to strengthen the argument that we don't need to invest in health systems. Let us make our homes more habitable so that then not only health professionals, like you said, but other professionals can stay in the country. So to that point, how should these leaders make the decision to invest in health systems, health infrastructure?
Well, first of all, I honestly, so people can live because of better salaries, but it happens also here in Switzerland. You can go and find a better job with a better salary. Yeah. But I think that the biggest problem, and I see talking to, I'm not a medical doctor, but my friends who are medical doctors, they cannot practice what they have been learned. They cannot do surgeries. They cannot do this. So they're not even being able to work as professionals. To fulfill. A doctor, being a doctor is a calling. You really want to save people and patients. So the issue of salaries is not an African. People in Switzerland can move from Geneva to Basel or live in France or with their better salaries. That's a normal thing for anywhere in the country. But I think the primary thing in Africa is not investing in health systems. When you don't invest in health systems, right, you can get a donation of vaccines or medicines, whatever. But with poor infrastructure, there will be no access. It will limit access to that. So I really think that the priorities in I've heard, I don't want to mention names of these countries. It's scary to discover how much money they invest in the military. What are you fighting? What are the wars that you're fighting? Billions, that they invest in the military. But are we at war? No, we're not. So I think some of the priorities for me are wrong. What we saw after independence in many African countries, there was a lot of investment in education, to train the people. And I think we've lost track of that. Now priorities have shifted to something else. Yeah, so I think that's what I would say. I think that, and I agree with you, people can move for better salaries, but I think the infrastructure, the systems are the reason they do it, because they cannot practice what they were trained to practice.
My name is Ruben. I'm studying economics. So my question is around, so we started with all these statistics about like number of doctors per 10,000 people and all that. And it's very clear that the population in Africa at least is growing at a faster rate than the rate of like number of professionals. It doesn't have to be doctors, it could be nurses and all that. So, and of course, when we do projections of population to 2030 or 2050 and all this, so, you know, everyone is talking about demographic dividend. Africa is going to have the highest population by this year. But personally, I'm worried because I'm not sure it's going to be a dividend, like in terms of the population growth, because I don't think the services, the goods, you know, the food supply is matching up that. So what is the implication of that? Because then when I look at the flip side, there is the whole argument, which I don't like, but I see it a lot in econ literature, is so there's now this argument about degrowth and depopulation and like, you know, to handle that, but I don't think it's a solution. So as experts on this, how do we balance? I mean, the population is really ballooning, but also like and it's not just health, it's like every sector, the numbers, the goods, the services, the professionals, the skills is not matching up. And I think that might create some, you know, maybe risks we haven't anticipated for the continent. What is your view of that?
Just want to thank you for this question. Maybe I just need to complete and then add.
Oh, no, you go ahead.
Okay.
Go ahead. No
Just
problem.
one aspect I would like just to stress out is this is a common perspective we usually just hear in the case of Africa. I think the human resource or population may be considered as, the increase of population may be considered as danger for the future. But I think that Africa is not so, we don't have like population if we compare her with the other continent. So for me, we have to take the problem in the other side, saying that we have a population, a growth population, increase of population. We have to just put in place all the conditions to just accompany this growing of population. We have a young population. If we invest in health, so you have a good human resource, you know, good health to develop the continent, if I just take things globally. So I won't take it as a threat, thinking that, okay, maybe we will lose. We have resources as well. Education brings skills professionals who will able to just take decisions for the country. We need to invest in leadership. We need just to see how this increase of population need to be managed, in my own sense. But for me, it's not like a kind of threat we will have. Our population, some of the continents are more important in terms of number of population than Africa. So for me, it's a kind of, not false debate, but it's may not the main issues. The issues are elsewhere. It's my idea. My perspective.
Well, thank you. I'll just make 2 points. I think for me, it's a positive. We have such a young population, and I think they are very entrepreneurial. Africans are very entrepreneurial people. We need to harness more of that. But also, if you look at Europe and other places, there's an aging population. And so you can be exporting people, yeah, if you want to decongest people. So I don't think it's a threat. It's actually an opportunity because we have such a young population. I think we need to. If I had a chance to rewrite the curriculum for any discipline, is to really introduce entrepreneurship at a very early stage. I think we are so much dependent on expecting governments to provide jobs and jobs. H3D. This is an example. This is entrepreneurship. We are not funded by government. We are not funded by university. We raise all the money that we need to run the organization. And we found partners. Government gives us some funding, which is very important to support the infrastructure. So the government of South Africa has made this priority to support, invest in what we do. We bring 70% of the funding we need comes from international sources. So it shows that it's possible to do this. If you build something and there's value, people will come for it. So I think we need to harness this creativity of young people. Unfortunately, there isn't really support for entrepreneurship. And I think that is, for me, what concerns me, is that there is no real support for supporting entrepreneurship that can really help the continent move forward.
Just to support this point you just stressed out, having a point as professor of development studies at Sunny University, it's the north of Senegal. So we reviving the curriculum, and exactly it's what it. After the bachelor degree, we have to introduce a kind of program, inviting the private sector, organization, just to train students, just to open their own firm, their own enterprise. I think this is now, not only in Senegal, but in the other countries, in African countries, we realize that the programs we inherited from colonization, from independence period, we just maintain until now, didn't give the result, the output we need in the continent. So now just thinking about pushing young students or young professionals, push them to create their own business is one of the kind of solution. Even academics try to help politicians or just politics to implement. And you will just take different countries and we have the same perspective, just reviving the curricula and helping young people just to open their own business. I think in Nigeria, is that anyone from Nigeria? Yeah. It's where you find many entrepreneurs, many young entrepreneurs with initiative in developing South Africa, less in Francophone countries, but now we have the success stories that we can just give as a good example. It's a kind of phrase of new way of developing the country.
Oh, sorry, Ruben, did you have?
Yeah, that was good.
Hi, my name is Lemlen. Thank you very much for being here with us today. I am just curious to know, based on your experiences, of course, Africa being a continent, a big one at that, a very large one. I come from the East, I'm Eritrean. Each country has its own history. We are ridden with conflicts and wars, so unfortunately, not having stability means that we can't quite achieve a lot of, the partnerships and all the things that we desperately need. You refer to, I think I heard IMF. I heard that for most African countries, education was a priority, especially in the 60s. Structural adjustment comes to mind. I am not a political science expert by any means. I'm curious to know to what extent policies and regulations, not just within our governments in Africa, but also external factors, are a barrier. Clearly, we need a mindset, a shift in the way that we look at ourselves. But what is limiting us? What would you say is our major barrier? So I appreciate your stories and your personal experiences. I think South Africa, despite the challenges and the history that it has, I would say is probably one of the most innovative and classic examples, I guess, in terms of achieving success. But what other African country can we really compare in terms of having access even to partnership, right? I don't know, I just wanted to hear a little bit of reflection of where we stand as a continent, so that we don't shoulder all the burden on ourselves, considering that we have a lot of Africans here as well. Can you reflect a little bit and share your thoughts, please? Thank you.
You want to go first? Or?
Yeah, please go.
Okay. Thank you very much. Well, I guess South Africa is not the only. I think Rwanda is a very good example of what is possible. I think when I was talking to a colleague today at the Medicines for Malaria Venture, they were telling me they hosted this big meeting that is held every 4 years. It was in Kigali, and he was telling me that all the foreign dignitaries from the US, from Europe, he said this is the most impressive meeting they've ever attended. is right in Rwanda, in Kigali. I've not been there myself, but that's a good success story of what is possible. I think you made a very good point about shouldering the blame. Sometimes we can be very hard on ourselves as Africans. We don't realize we've made a lot of progress actually. And there's some external factors that are really beyond in our control. But there are things that we cannot really control. But there are many things that we can control. So, for example, many of the governance issues that we have, corruption. First of all, corruption is a human problem. There's corruption everywhere in the world. But when we have such weak governance systems where there's impunity, there's no consequence to that, and then people just, one of the big problems that we have, whether it's mediocrity in the bureaucracy, poor service delivery, corruption, rigged elections where the will of the people doesn't really matter. So those are things that depend on us. I don't think that we can blame an outside person for being cruel to our people or not giving them the rights and so on and so forth. And of course, I give the example of, I come from Zambia. So Zambia is mostly copper mining. And many African countries also have resources, whether it's oil or whatever. We know that you can add value to your products by maybe doing some, some purification or something. But because I believe, I don't have to mention names here, but I really believe that people know that they benefit from having this kind of scenario where the minerals are shipped to wherever, London or whatever. And then they're purified and they're made into some value, there's value addition, then they're sold back. So someone benefits from having that system. And this is an African who benefits and doesn't want to see change because it benefits them. The same thing with the regulators, They don't want harmonization because they're the middlemen so they stand in the way of finding a solution they know is a problem here. So I think there are things that are beyond us. There are systems out there that are very complicated. The markets are here. But we don't even trade amongst ourselves. We don't even trade. We don't even allow each other to go into another country. We need a visa to visit. And people complain about visas. We also have visa regimes in Africa that are very difficult. You can't visit easily. So imagine if we cannot even visit each other's countries easily, if we cannot even trade amongst ourselves, how do we start blaming someone else? So I think there's a lot that we can do. But I also believe that there are things that are external, that are someone who controls the narrative is outside the continent.
I will just add, just to summarize, what you say, is three levels of understanding of the case. The first question is why Rwanda's success to be Rwanda? Couldn't one, because they have a strong leadership and administration, a strong institutional power as well, and population believe that they can just make it. This is important. And it's the kind of decolonizing the mind of your population, make them know that you don't need to wait for someone coming from outside to develop us. This is the first thing, taking the case of Rwanda. The second thing is nationally. You all describe the challenge African population face with their administration. In Senegal, we have civil servants that are billion. Yes, of course. How can you just justify corruption? How can you justify bad governance? It's not like coming from outside, it's coming from internal. We have to just see these realities, sad realities, before just saying outside. You're giving the example of we don't just trade between countries. I'm from Senegal. My mom is part from Guinea-Bissau and Senegal as well. We are evolving ECOWAS areas. We support just to move freely from one country to the other. Just leave the capital of Senegal, trying to join the south of Senegal because we have Gambia. You're gonna pay You're supposed to just move freely. You're gonna pay. If you arrive in the South, you would like to just join Guinea-Bissau, the border, you're gonna pay. As Senegalese pay, those coming from Guinea-Bissau pay. Why do we suppose just to just move freely? This is the sad reality we have there. And the third level is globally. We have some of the regulation, some of the international regulation that just limit this kind of mobility, visa restriction, and also just recognize some of the, if we take the example of trading, how can African entrepreneur trade with European country? You need to fill 100 or just 1,000 requirement before doing it. So we have also this inequality. It's a different level of just understanding we need to take into consideration to just studies or understanding the case of Africa. It's more or less complex.
Yes, I'm gonna be very quick. My name is James. Thank you very much for being here and for sharing your thoughts. My question is going to be on access to healthcare in Africa. And one of the biggest challenges is the fact that the manufacturing of health products in Africa is not at its best shape at the moment. I did recently see a figure that just 1% of the vaccine doses that are actually needed in Africa are manufactured in Africa. And my theory is that what that does is it increases prices of not only medicine, but also vaccines, and it makes it obviously, more inaccessible to people that do not have the resources or the finances to afford that because of import tariffs and long supply chains. I won't ask you what the solutions are because we've had policies around it. We've had a lot of chatting around it. So my question would be, so what is the root issue here?
So I can have it go, yeah.
Yeah, because your project is well
Yeah,
known in
yeah,
Africa.
yeah.
So as opposed to when it's access, you're
Right.
giving it the price of medicines.
Yeah. So the actually one of the things that we started doing in H3D is we have a project on local manufacturing. Let me give you 3 things that I think are a problem. The first one is also similar to the matter of clinical trials. Government policies that do not prioritize local manufacturing. In fact, for good reason, they say procurement, government procurement, you have to go to the cheapest supplier. So that's one thing, yeah? So if you look at Indian generic companies, you cannot compete with them because they get subsidies from their governments. You can't compete with them at that level. So there hasn't been policies to encourage and incentivize local manufacturing. Let me give you an example. Just out of the COVID pandemic, the outcry about whether it's vaccine manufacture or medicine manufacture. The market in Africa for medicines, most of it is formulation. The active pharmaceutical ingredients, APIs, they are imported from India and all these places. So you cannot talk about self-sufficiency and local manufacturing if you cannot bring in cost-competitive technology. Because why should the government buy from you when you're expensive when they can buy things cheaply? So the challenge is for us as well to say, how can we work with partners, whether it's pharmaceutical companies or whatever, to do technology transfer that allows us to be competitive price-wise. Thirdly, skills. So policies that favor local manufacturing, incentivize them. Secondly, cost competitive technologies. Thirdly, skills, critical mass of skills. There are 4 companies that I know in the whole of Africa that can manufacture active pharmaceutical ingredients, okay? 2 in South Africa, 1 in Egypt, 1 in Nigeria. they have not been supported. We are hearing about all this money that's sitting around for local manufacturing in Africa. And there's no financing for those companies. They are struggling and they could collapse anytime. So again, you wonder, why is there so much talk and noise about local manufacturing when there are companies that are already there that you should be supporting to succeed, not to survive? The same thing, you know, the people that go back to Africa to work, they have these poor conditions, and then we say, oh, we don't have enough people with skills, and then Africans in the diaspora, why should they come back when they see the people that went back? You know, the system destroyed them. So yeah, I think there's a lot we can do ourselves. Look at ourselves first before we start blaming someone else, because that's government policy to do that. So that's what I would say is how we can address this issue of local manufacturing. And we're doing that. We have a project actually funded by USAID. And we have brought in this cost competitive technology. We have partnered with a local company. When we demonstrate that we can really cost competitively manufacture these 3 antiretroviral drugs for AIDS, then the local company that we're working with, CPT Pharma, can commercialize that process and then produce those active ingredients cheaply on a commercial basis.
Sorry, we're out of time just on the questions.
Oh, I have 8 minutes.
We have one final question and then mingling. So, would you like to go ahead with the last?
Yes, sorry. I think our last question was a bit partially answered throughout the question we had here and there, but it was on the way forward. So, you know, I give you the educational settings we have in Africa. What is the play that youth has? But I think you answered that partially. So I would like to ask another question, if you allow me, that came a bit throughout this here and there. It was the role of other African, a bit more, make it easier. So I was wondering, what is the role of the private sector in Africa? You mentioned that before, but for instance, in your expertise, in your experience with H3D, how much of your, not the percentage, but you know, how much of success did you have with other African countries engaging other private actors first? Also, we talked a lot about those. You said there are 4 manufacturing companies, but we also learned during our research that the CDC, so the Center for Drug Disease Control in Africa, was founded in 2016 in Addis Ababa, you know. So we see that it's very young as well. How all of those questions, sorry. And so my final question is, you know, were you able to engage with other African countries, other African leaders, and also at the private level? Sorry. And yeah, I would stop here.
Okay. So private sector funding from Africa, zero.
Okay.
And there's no appetite for that. Private sector funding from overseas, yes. Okay. We have been supported by pharmaceutical companies. Some of them gave us grants without no strings attached, but as you know, part of the philanthropy to help us build infrastructure because they saw what we're doing. But there is no appetite there is no appreciation of research and development. You know, this perception that they want to make a quick buck. So when they invest, they want to see returns, you know. But in this business of discovering medicine, it's a long process. You have to take a long-term view. It's very high risk, but also high reward when it succeeds. So we need to think about, it's not just the investment in the research and development to find solutions. You have to remember this, but when the science is happening, when the research and development is happening, you are creating jobs, you are creating career opportunities. You don't discover the drugs overnight. It's a long process. In fact, many things fail, they don't work. Yeah. But even if you are failures, people have jobs. People in H3D, those are real jobs people have. And yet we haven't discovered a blockbuster drug, but that's not the point. We had to build the infrastructure first. And that infrastructure, we started with one program in malaria. Now we have malaria, TB, and this antibiotic-resistant microbial diseases. Because the infrastructures can be repurposed. We can move to another disease area as long as we can get the funding to do it. But the infrastructure is there, it's been developed, it's world class, so we can work on anything. So, yeah, the private sector in Africa, I think, needs to have the appetite of thinking about long term. I think too much of it is left only to the public sector, which is not fair.
And thank you. And if you want to add on that?
I think he really summarized it at the beginning of this conversation. I was talking about the private sector involved in the provision of health services. It's exactly this appetite of money, quick doors, and they won't. That's why when I'm going to take the cases, I better master Senegalese cases and West African cases. You put private sector there, they're going to just open their private services, not using the generic medicine, so try to sell the expensive one to take the benefit. So this is a kind of prejudice we have, but sometimes it's a real, not only prejudice, but it's a reality. And if you put the private sector, you put the public sector, all come to public sector, and private sector is here to make benefits. Simply said.
And maybe the real final question. So, do you have any advices for us here? You know, there are many students or alumni as well, but African students or from African descent that want to engage. So, do you have any recommendation or a wise words for the future? That would be my
I say just three things I always share. I don't think there are formulas for success. Different people have different paths, but I always share three principles. I think the first one is opportunity, being grateful for whatever opportunity that you have. Yeah, there's so much we can take for granted. Just the fact that you are here, we must be grateful. Yeah. So what happens is, if you don't take that opportunity, okay, you might miss out on many things. So when you take your opportunity, you make the most of it. Before you know it, one thing leads to another, because you took your chance. So that's number one. Make the most of the opportunity that you have, because you never know where that might take you. Secondly, consistency. If you see something, you have a vision for something, you have to be consistent. People give up easily. They give up easily because they want a quick fix solution. But if you believe in something, just be consistent. Don't allow other people to talk you out of a dream, in a vision. Just be consistent. Walk in your lane. Don't look to the left or to the right. Just keep doing what you believe is the right thing to do. And the final piece of advice I give is, you have to remember this. Yeah, every person is unique. Yeah. So I get inspired. There are people that inspire me, yeah? But I don't have to hero worship them. I don't have to over-respect them. So people who make history don't suck up to history. They don't conform to history. You have to believe that you are unique, yeah? Because you know what is your strength. I know what is my strength. I know what I'm not good at, yeah? So I'll focus on my strength. So if you start, you hear about this successful person. Okay, they are successful, but you don't know what they've been through to get to that point. They had to start from somewhere. So people want to follow what other people have done because it has been done. But people who make history, they stick to what they believe, and they believe that they're unique.
So I will come with 4 points as well. First of all, for those who have African background, refuse just to take the challenge, African challenge, on your shoulder. It's not what you need to do. Be confident, and just know that Africa now, as continent, and different countries have different level of development, but opportunities in Africa are just huge. So don't just focus only, we talk about health systems, health inequalities. It's a heavy subject. But in the others, like domain, even in health, opportunities, you have opportunities. So be proud of being part of Africa, and just let me tell you that the future is in Africa, in all sense. The future is in Africa, in terms of technology, in terms of transfer of technology, partner, private partner, in terms of opportunities like in development, economy, and all of these domains. Africa is a place to be in a few coming decades, I may say. So be confident and just be proud that you have future in Africa, despite all we talked about. And we need leaders to just propose exactly what African countries need. Don't forget that we have population that need to be educated. We have potentiality in education, in health, in economics, in different domains as well. So this is the point I just would like to add.
Thank you. Thank you very much. I think now we will have a little apéro without alcohol, but it's